But then things began to change and life got more difficult. While I was in physical therapy school, the Salk vaccine for polio came out. And so actually the number of acute polio patients I saw was limited. And what began to happen was patients with central nervous system pathology, head and spinal cord injuries, stroke patients, and then a few cerebral palsy where I worked, became our major population. And this presented real problems. So the treatment became particularly challenging because now instead of muscles that didn't work, we had muscles that worked too much. They were very, very active. No one understood the disordered motor control that went with a lesion of the central nervous system. In particular, the prevailing spokesperson on treatment was the BOBAS, and now known as NDT, neurodevelopmental therapy. And they said we can't stretch them because it would make the spasticity worse. They said we can't strengthen the muscles because it'll make the hyperreflexia worse. So we had no guidelines on what to do or what to expect. So it was a real try to figure something out as you went along situation. So again, I'll just tell you that I saw primarily the neurological patients, but we still had musculoskeletal pain conditions. And those pain problems were believed to result from acute injuries. And we used modalities to treat them because actually the anti-inflammatories weren't developed until later on. So physical modalities were an important source of trying to reduce pain and symptoms in these patients, as well as to try to strengthen muscles to restore what was believed to be injured. It's also kind of interesting that there weren't that many joint replacements, so people had a lot of osteoarthritis type pain problems. And it wasn't until the 60s and 70s that joint replacements became a part of the intervention for people with osteoarthritis. And I stopped treating musculoskeletal patients because I once had a referral that told me to use this microtherm, the machine you see pictured, Director C at 20 inches for 20 minutes. And I decided that I didn't need to go to college to learn to do that. So, and then telling me to do quadricep strengthening and hamstring stretching. So I put all of my efforts and would only see patients that had neurological problems for the most part, where the doctor couldn't tell you what to do because it was clear they had no idea what to do, nor did they on the others, but they thought so. And this is just to show you that these are a checkoff list. And later on in my career, doctors would call me and say, Shirley, what should I check off on this list? They had no idea what to do. And I don't know why we asked them to try to do that. So sort of the summary of the first 5 years for me, 1956 to 61, so you still don't have physical therapy in Japan yet, was my belief that the physician understood the patient's problem and made the diagnosis. That with a neurological patient, certainly wanted to help with functional activities, but I wasn't sure how to do it, whether we were trying to restore limb function because they had all these muscles working, or just practice functional activities. And how could I do that without making their spasticity worse? How could I reduce it? And now my belief is we need to try to understand the motor control problem just to plan the treatment program and to make a prognosis. And I'll try to be a little more specific as we go on. I will tell you that I am so intelligent that it took me 9 years to figure out I didn't know what I was doing. And before I call it escaped to graduate school to get my PhD in neurobiology so I could try to figure out what I was doing. Okay, so for the musculoskeletal patient, as I said, they thought they were acute problems. We wanted to relieve symptoms, increase range of motion, and strengthen weak muscles, but it was becoming clearer and clearer that the physician didn't understand this disordered motor control of the patient with a central nervous system lesion. And we call that a pathokinesiological condition. So when the nervous system is injured, you move abnormally because you have a pathology. So the pathology induces movement problems. So the highlights are treating this disordered motor control was a challenge because there was no understanding of the problem, and it was so different than what the polio patient had been. And I actually participated in a study by the government that determined that we physical therapists were professionals and not technicians because we actually made decisions. I don't know that the decisions were very good, but we did make some. And all the other patient problems were considered to be acute or a sudden onset. I had no belief that I would have to identify the factors contributing to the patient's movement problem. I just had to get them stronger and keep their range of motion going. It was a lot of cheerleading.
Mm-hmm.
So sort of the next developments in this is the treatment systems were developed. The BOBATH treatment, the PNF, proprioceptive neuromuscular facilitation. Brunstrom had a method, Rude had a method. Treatment became highly variable, which it still is today, because there was no real understanding of the underlying problem. In musculoskeletal patients, the same thing sort of happened, is that we developed manipulative or manual therapy that were all based on the concepts of Cyriax, who was a physician in England. The emphasis was trying to look for the source of the pain in the tissue. And so the emphasis was on what is the pathoanatomical problem of this musculoskeletal system. And so then again, treatment was named for the developer, Maitland, Kaltenborn, Paris, and McKenzie also was a form of treatment. A little more self-treatment, but still related to a joint problem and still considered an acute situation. My question was always, why did the problem develop in the first place, and what are we going to do to keep it from returning? Probably the major contribution for manual therapy was that therapists trying to figure out what the problem was, because we never tried to figure out the problem before. Sort of the unfortunate side is treatment became passive, and it wasn't until many years later that some form of exercise was incorporated into manual therapy. By the 1970s, in the profession, there were questions being raised. And the question was, what is physical therapy? What is our body of knowledge? And our responsibilities seemed to be changing, but we didn't know what kind of big picture to put those changes in. And there was trying to understand the underlying conditions was just getting started. So these were examples. In 1975, Helen Hislop suggested that our body of knowledge was pathokinesiology. In the 1980s, where I was, a new director came to the physical therapy program, and he wanted to build the curriculum around pathokinesiology. He wanted to develop classification schemes for low back pain in particular, diagnostic categories. And he wanted to develop a research program so that faculty became academics rather than just school teachers. He had a great saying that says, practice needs more research and our research needs more practice. As indicated, his classification was based on an exam that was much like McKenzie's, but they had more treatment categories that was named for the treatment: manipulation and exercise, stabilization, centralizing with extension exercises, and then traction. Okay, so and meanwhile, another group, including myself, was beginning to develop other programs. And Steve asked me to see these musculoskeletal patients with him. And I gave them programs like I had given my neurological patients, and they got better. And I also taught them how to run differently or walk differently. And these are some pictures of the before and afters of these early patients. And you could see how much they changed by teaching them how to move differently. So we started a classification system based on the symptom response to movement and to correcting that movement. Both of these individuals were runners. The fellow was a 10K runner, And the young woman was an ultramarathonist, and he had back and foot pain, and she had hip pain. And he not only got better, he was 2 minutes faster in the 10K, and she was able to resume running after 5 months of not being able to run at all.
Wow, that's great.
There was also changes going on in the physician education, because in the early years, actually, medical conditions were identified by an anatomical location. So they had extensive education in anatomy. But by the 60s and 70s, the emphasis became on biochemistry, because biomechanical factors were now identified as more important to medical conditions than anatomical location. And of course, the radiological techniques and technology was also developing in a major way, and they could see the tissue changes that had never been visualized before with MRIs and CAT scans. And the same thing was true with neurological conditions. They could be visualized as they never were before. So physicians became much more interested in the pathoanatomical, biochemical types of problems, and there were now more drugs to treat the symptoms than what we had before. And today, by contrast, at our university, our medical school, the medical students only spend 1 week on the anatomy of both extremities together. And I know in some schools, they don't even teach anatomy of the limbs. So the emphasis in medical education is entirely different than it was in the early days of physical therapy. The other thing that happened that was very influential in my life and many lives was a physician that I worked with at Washington University, who was demonstrating clearly that lifestyle had a lot to do with your health. And his studies involved both animal rats as well as people. And he used physical therapy faculty in his studies to conduct exercises in the elderly, and clearly showed that with exercise and diet control, you could reduce the incidence of heart disease, diabetes, blood pressure, and that old people could also have a training effect. It wasn't just for the young people. Mm-hmm. And this is a very important message, is that it's very clear now that most health conditions begin early in your life and slowly progress over time. And important to us as a professional is exercise is an effective treatment for preventing or slowing down everything from cardiovascular disease, diabetes, cancer, dementia, and it reduces inflammation. And of course, now inflammation is believed to be underlying most diseases. And so what medical education and practice is focused on is the immune system and genetics, appreciating this big role of inflammation in disease.